welcoming all the viewers who have joined us today on the Bombay Orthopaedic Society YouTube channel, the OrthoTV channel, and other platforms where this is being relayed. I will take this opportunity to welcome the convener of this meeting, of this webinar, Dr. Ajay Puri, who is the Director of Surgery at the Tata Memorial Hospital in Mumbai. And we have got a host of faculty from India, including Dr. Yogesh, Panchwagh, Mishil, Parikh, and Prateek Hegde. And with us from across continents is a committee as a group from the British Bone and Joint Journal. We are honored to have the president or the editor-in-chief, Professor Farez Haddad, and along with him are Mr. Sam Patton, Professor Jeys, Professor Laitinen, and Emma Vodden, who is the head of publishing at the BJJ. Thank you all for joining us and helping us to get this meeting together. I'm going to give you a brief introduction about the Bombay Orthopaedic Society. Bombay Orthopaedic Society was established in 1965, and we are celebrating its Diamond Jubilee. That is 6 years of academic excellence over. And we have been doing this climbing on the shoulders of some legendary orthopods whose contribution to not only orthopedics in Bombay, but orthopedics in India and across the globe is immense. How did it begin? The first orthopedic surgeon in Bombay was Dr. R.J. Katrak. He established the first orthopedic unit in India at the Wadia Children's Hospital in Mumbai. Subsequently, he also established the first academic teaching unit, which at the KEM Hospital in Mumbai, and he was the first Indian to be awarded the honorary fellowship of the British Orthopaedic Association in 1964. The early years were years of struggle where there were few members because there were very few orthopedic surgeons in India. BOS was established in 1965, and it was the first exclusive orthopedic association in India. Prior to that, the Association of Surgeons of India did have an orthopedic section, but there was no separate association. Dr. Katrak was its first president, and Dr. Ellen Vora was the secretary. And we had some eminent orthopedicians who were pushing this agenda through, like Dr. A.K. Talwalkar, Dr. K.T. Dolakia, Dr. Kini, etc. In the early years, meetings used to be conducted bi-monthly, and the meetings were principally clinical cases which were discussed thoroughly in order to benefit the audience. Every 6 monthly, a lecture program was held, which was conducted over a period of 3 days. The first Western India Regional Orthopedic Conference, which is the annual meeting of the Bombay Orthopaedic Society, was in November 1966. And at that time, the Bombay Orthopaedic Society was very proud to host traveling fellows from the orthopedic section of the Association of Surgeons of India. In the subsequent 3 or 4 decades, BOS saw rapid growth. The membership grew by thousands, from initially having a few 10 or 20 members. Today, we are at 4,000 members. The BOS started having monthly clinical meetings and master series CMEs on various specialty topics. The BOS at one time used to host 27 courses on various subjects across the year. These were basic courses, advanced courses, and specialty courses. BOS also runs the JCT or the JC Taraporwala postgraduate teaching program and has various fellowships and observerships under its domain. VIROC is the premier academic event It is attended by almost 1,700 orthopedicians from across India and from neighboring nations like Sri Lanka, Bangladesh, Nepal, and the Middle East. The Journal of Clinical Orthopedics is the official journal of the Bombay Orthopaedic Society, and it is published every 6 months. Bombay Orthopaedic Society has also developed protocols-based app, which is an online app, which is available so that you can formulate consents for your patients who are undergoing surgery. BOS research extends to their work on osteoarticular tuberculosis. Their first project was between 2004 and 2007, and the second osteoarticular tuberculosis project was between 2007 and 2009, and this research has been published in international journals. Where do we stand today? Today, BOS is an academic powerhouse. It interacts with various societies across the nation, and directly and indirectly, BOS has contributed to influencing orthopedic education amongst 1/4 of all practicing orthopedic surgeons across India. What is the way forward? As I always say, our legacy is strong, but if we are together, our future is even stronger. We need to innovate, we want to educate, we want to collaborate and elevate orthopedic care in India and across the globe. With this in mind, during my presidency, I have come up with this program which is called BOS Worldwide. We want to share our knowledge, experience, and expertise across the globe. To do so, we will be having worldwide webinars with various international societies every month. BOS will be traveling to different second and third tier cities across the country on a monthly basis. We will be sending our faculty and having a CME or a workshop in these cities. We are planning 4 recorded live surgery symposia where around 15 surgeries will be telecast to 25 different cities across India. And we have planned 4 such symposia across the next 1 year. In December 2025, during YROC, we are releasing the first of the BOS monograph series. This consists of 6 books on various topics of interest to general orthopedic surgeons. And BOS is also expanding its fellowship program. Just to tell you about what is to come, next month on May 4, we have a program, the Master Series, which is a physical program on complications of hip fractures and salvage. The next worldwide webinar after this one is going to be in collaboration with the Canadian Pediatric Orthopedic Group, and the topic of discussion is going to be the pediatric hip. The outreach program next weekend is in Aurangabad, and again we are the first day there we are going to do a postgraduate teaching program, and on the second day it's going to be a session on pediatric trauma for the general orthopedician. The month after that, the outreach program travels to Bhubaneswar in Odisha, where we are going to have a CME, 2-day CME on surgical site infections in orthopedics. Next month, we have a live hand surgery symposia. As I mentioned, about 15 surgeries are going to be shown at this program, and it will be telecast to 25 different cities across our country. We also have our basic hand course at around the same time. This is going to be on a format of 7 days, and delegates who attend the meeting will not only benefit from lectures and clinical case discussions, but they will get an opportunity to visit the OR, assist in surgery, and observe the masters at work and hobnob with them so that you can look forward to networking and building your career in the future. Finally, it's not all works and academics. For the first time in many, many years, BOS is going to have a picnic in the monsoons to Karjat. And I welcome all of you to this program. We are going to have a grand time. Do not miss out on this opportunity. And finally, the grand event of it all, YROC 2025, is going to be held between 26th and 28th December at the Westin Hotel in Mumbai. So to conclude, we have a legacy of excellence in orthopedic education, but our vision is for continuing progress and innovation. Join us, join BOS in shaping the future of orthopedics. Thank you. And with that, I would like to hand over the mic to Dr. Ajay Puri, who will be taking over further.
Thank you, Gautam. Thanks for this excellent introduction to the Bombay Orthopaedic Society. Hi, everybody. Good day, wherever you are. So when Gautam discussed the concept of having these worldwide webinars with me and focused on bone tumors being the first webinar, we thought of making it a little different. Our webinars essentially had been case presentations, and we used to discuss cases where we, fielded queries from the audience, etc. I thought we'll make it a little different. Orthopedic oncology has a small number of cases compared to other orthopedic specialties. So if you really look at evidence-based literature, there isn't any level 1 evidence for most cases. What we do is what we have seen, small case series, etc., published across the many years. But this can sort of collectively still contribute to evidence. And we had what is known as the BOOM meeting, and I'll ask Professor Jeys to brief us on that later, where we decided and a group of experts met, and not a group, actually, a large number of experts met and decided on consensus guidelines for simple things that we see every day. This paper got published in the BJJ. The BJJ, the Bone and Joint Journal, was originally the JBJS British. And for those of us who trained in India, it was the go-to Bible. That was the one journal that we all addressed. And I'm really privileged and thankful to Professor Haddad, Sam Patton, and Emma from the BJJ for joining us and collaborating with the BOS in this webinar. And it's actually a privilege to have all of you here and be able to tap your thought process as we go along the meeting. So we are going to focus on the BOOM paper that was published in the BJJ. We'll get the lead authors, Minna and Jeys, to speak to us about it. Then we will move behind the scenes, and Sam Patton is the oncology editor-in-chief for the BJJ. He's going to tell us why he sort of selected this paper, why he thought it would be impactful, and accepted it in the BJJ. BJJ, in fact, has a very small rate of acceptance of the papers submitted to it, and that's why the high quality is maintained. After that, Professor Haddad will tell us about the challenges that we face in publishing in today's era, what is the way forward, where he sees how we are going to go henceforth. And then the BJJ has a lot of educational initiatives for young and practicing surgeons. And Emma, who is the chief of publishing, will brief us on that and how we can actually use that to leverage our knowledge, to publish, to learn better. And hopefully, at the end of this first part of the discussion, we'll all be a little more knowledgeable about how we can sort of tap into the BJJ's educational initiatives. The second half will be clinical case presentations, and I have an eminent panel between Yogesh, Panchwagh, Mishil, Parikh, and Prateek who will present cases. We'll be happy to take questions from the people who are attending and try and address common problems in orthopedics. So without further ado, I'd request Professor Jeys to try to introduce the BOOM concept briefly, and then Minna can take us through the salient points, the consensus points that were agreed on in this meeting. Over to you, Lee.
Okay, thanks very much. We'll try to just give a brief introduction of what we did. Okay, so BOOM, it was a consensus meeting, we said. We had it in Birmingham in January 24. We had 309 delegates from 53 countries, and we developed 41 questions, and we looked at the evidence and debated it. So we tried to get it from all around the world. And the reason why we did it was because this is just a snapshot of my phone, lots of different cases from around the world of people asking what to do in this serous chondrosarcoma. And we can look at the evidence, but there's, a lot of papers out there, and it's very difficult sometimes to try to sort the wheat from the chaff for the orthopedic surgeon. And often the literature tries to put apples and oranges together. And the idea of the meeting was really to just answer some very simple day-to-day problems and try and tease out the literature. And we know that in oncology especially, ROH has a large database. We hold all the answers, but, in other parts of the world, it's down to tumour registries. But what we do know is that the incidence of low-grade chondrosarcomas was really rising, but the rate of high-grade tumours wasn't rising. And that radiology can be difficult to interpret what's benign, what's low-grade, or what's high-grade. So I gave a talk in America about controversies in chondrosarcoma, and it turned out to be pretty controversial. And so we realized that it probably was a good idea to try and get people from around the world. So we started the concept of the Boom meeting. And basically, we formed a scientific committee. So we got 150 units from 47 countries. We got some regional leads. We developed 125 questions, and then the scientific committee prioritized those questions into the most important for them, giving us 10 themes in chondrosarcoma and 10 themes in PJI. We also used the opportunity to look at access services for around the world, and this has just been published in the BJO literally yesterday. And then we got 2 different units from 2 different continents to research the same questions, and then put all the evidence together. And so this is available, the evidence is available with the paper, but also to download for free. It's now probably the most up-to-date evidence document in chondrosarcoma. They developed the 2 centres then developed a consensus statement, and then basically we debated it. They presented their evidence, and the bodies then debated it in the meeting. We had some independent moderators who were experts in their field but were allied with the field. So Prof Brennan's a pediatric oncologist, so wouldn't normally treat chondrosarcoma, but has a lot of information about cancer, and Ridley Morgan-Jones, who's a PJI surgeon, but again doesn't do tumours. And they were there to basically make sure that the process was fair. We tried to limit the amount of talking just to 2 minutes if people were making statements, and we tried to agree whilst disagreeing. So we had lots of fun, some debate, some argument about the questions. We were allowed to change a couple of wordings within the statement, but not the sentiment of the statement, depending on, and nothing against the evidence. And then basically the delegates voted. So we used a consensus strengths based on the ICM, but we added in one more, and I'll let Minna talk about the results. The statements are all available in the paper to download for chondrosarcoma and also on the website. And post-meeting, we looked at feedback, and again, we received excellent feedback, and many people thought it was one of the best meetings that they had been to, because it was a very different kind of meeting. So that was basically the concept, and then I'll let others talk about the results.
Thanks, Lee. Can I request Minna to actually list out the questions that were asked, the salient ones, and how the audience polled regarding the consensus? Over to you, Minna.
Yeah, thank you, AJ, and thank you for inviting me here. I just tried to share the PDF form from the paper, but I'm not sure. Did I access it now? Do you see my view? No.
No, we're not seeing that, Minna.
It's I'm sorry for this.
No worries, you can just list through them and we can discuss them.
Yeah, okay. So basically I wanted to show the PJJ paper, because when we started to discuss about the questions, what we wanted to discussing this consensus meeting, we actually at the beginning, I think we had like 120 different questions that the people wanted to make state consensus about. But then at the end, we had 10 issues and 20 questions. And the first one was about the radiology of cartilage tumors, that which imaging features gives the best positive or negative predictive value for differentiating an enchondroma from an ACT. And the statement was that the presence of soft extension or cortical destruction or perilesional edema were highly suspected of high-grade lesions. And then another issue about the radiology was that can chondrosarcoma be safely diagnosed by radiology alone using the radiology classifications like the Birmingham atypical cartilaginous tumor imaging protocols. And then one big issue was the surveillance of chondrosarcoma, that what is the optimal clinical radiological surveillance following the chondrosarcoma resection, and should we stratify by risk? So should we, and the consensus said that we should stratify by high and low risk protocols, that minimum imaging includes radiographs and MRIs. And then another question was in the surveillance of chondrosarcoma was that is it safe to undertake radiological surveillance in atypical chondroid tumors? And what would be the optimal interval between scans, and when should we intervene? And I find this is a very, very interesting question, that what would be the safe surveillance system? And then about one of the very interesting issues was about the intraosseous ACT or chondrosarcoma. That what do we think about the purely intraosseous central cartilage tumors or ACTs or chondrosarcomas? Do they metastasize? And the conclusion was that the metastatic potential of the purely intraosseous cartilage tumors is negligible, and an extraosseous mass is a significant prognostic factor for metastatic potential. And there we got a very strong consensus, about 95%. But then there was a very difficult question about how should we treat the intraosseous ACTs or chondrosarcomas, and that was one of the statements where we didn't get any consensus at all. So only 52% agreed with the statement that purely intraosseous ACT or low-grade chondrosarcomas can be safely monitored without imaging. And for those patients with documented radiological progression or new symptoms, should be how should they be treated, with curettage or with resection? So that was one of the questions where we didn't have any consensus at all. And then, is it safe to avoid biopsy in radiological typical ACT or chondrosarcoma? There we got strong consensus that we can avoid biopsy. And then one question or one area was the local recurrent disease. Does local recurrence influence the prognosis of chondrosarcoma? And we got a very, very strong consensus of 99% supermajority that high local recurrence in high-grade tumors is influencing the survival. And how aggressive should we then be treating in locally recurrent disease in chondrosarcoma? And the statement was that they should be treated aggressively with wide excision if restaging showed no evidence of metastatic disease. And then one area was the dedifferentiated chondrosarcoma, which we all know is a totally different disease. And how aggressive should we be with surgery on dedifferentiated chondrosarcoma? And there was also a very strong consensus with 99% that dedifferentiated chondrosarcoma, being a very aggressive disease with a high proportion of patients with pathological fractures or metastatic disease, should be treated curatively if the disease is isolated, so without any metastases. And then another question about the dedifferentiated chondrosarcoma was that should we routinely use adjuvant or neoadjuvant chemotherapy with localized dedifferentiated chondrosarcoma? And there was a strong consensus that there is actually no really good evidence that adjuvant or neoadjuvant chemotherapy has any benefits. So the routine use of neoadjuvant or adjuvant chemotherapy for localized pelvic dedifferentiated chondrosarcoma has less evidence in the literature. And then there was one very interesting area about the surgical margins. What is the wide margin in chondrosarcoma? And there was just moderate consensus about what is a wide margin in chondrosarcoma. So for low-grade conventional and peripheral chondrosarcoma, more than 1 millimeter should be enough. And in central, we aim for 4 millimeter, but that got only moderate consensus with 77% of a majority. And then should we vary the attempt of surgical margins depending on the grade of the chondrosarcoma? And that got a very strong consensus that preoperative decision of attempted margins should be taken into account about the clinical behavior, imaging findings, patient choice, histological diagnosis when we have it. And then the treatment in inverted margins and do intralesional margins for high-grade chondrosarcoma increase the risk of poor oncological outcomes. And we got a very strong consensus that intralesional margins for high-grade chondrosarcoma significantly increase the risk of local recurrence and metastases. And then what is the optimal treatment following an inadvertent intralesional margin of high-grade chondrosarcoma? And there we had also quite good, strong consensus that following intralesional margins in high-grade chondrosarcoma, we actually have two strategies. Either we attempt a second surgery to achieve wide margins, or then we just have a close observation, and if there is a local recurrence, that we do wide surgery. And then pathological fractures influence the outcome for chondrosarcoma, and we know that the pathological fractures represent in total a more aggressive form of chondrosarcoma, and they result in increased rates of local recurrent disease, but the influence of the pathological fracture on disease survival is less clear. And is limb salvage safe with pathological fractures? We have a strong consensus with 94% that they again represent a more aggressive form of chondrosarcoma, but limb salvage may result in higher rate of local recurrence, but again, the amputation does offer a big survival advantage. And then the pelvic chondrosarcoma, which is of course interesting in chondrosarcomas, as 30–40% of the chondrosarcomas appear in pelvis, that do pelvic chondrosarcomas behave more aggressively, and therefore should they be treated more aggressively. And the central version of the chondrosarcomas are more likely to have worse prognosis and prognostic factors, and surgical treatment should aim for wide margins. And then does navigated surgical resection result in better oncological outcomes? And there we had also strong consensus that navigated surgical resections with either navigation or jigs may result in more accurate bone margins in selected patients and thereby reduce the local recurrence. And then the last question or the consensus statement was about the adjuvant treatment. What is the role of the adjuvant treatment, radiotherapy, proton therapy, and chemotherapy in conventional chondrosarcoma? And there was a strong consensus that there is no evidence for the use of chemotherapy in chondrosarcoma. And the very last question was, is there a role for alternate treatments in chondrosarcoma like cryoablation or RFA or ECRA? And there was also a strong consensus that cryotherapy may be useful in adjunct to curettage for low-grade chondrosarcoma, but radiofrequent ablation and cryoablation have very limited role in the treatment of primary tumors, but may have a role for palliation. So quite much of a strong consensus, and then these few issues where we didn't have consensus at all.
Right. Thanks, Minna, for sort of putting in very brief what was the two-day meeting. Sam, I'm going to now ask you, as Oncology Editor-in-Chief of the BJJ, what made you select this paper for publication? And you don't have to actually restrict your answers to this paper. What, as an editor, do you want in a paper to be able to accept it? What is the message that you feel can be conveyed, etc.? And just, it's free reign. Please feel free to tell us everything.
Right, AJ. Well, there are, of course, a number of oncology articles that get sent from all around the world to the journal. And as Lee alluded to a little bit earlier on, most places in the world don't do an awful lot of these things. So actually getting a concept of what's going on in the world is actually quite difficult. And the big units like Lee and yours, AJ, produce a large number of good papers, and we depend on those for our knowledge. But the consensus paper is an interesting one. I'll come to that a little bit later on. But the first thing I look for when I see a paper coming across the desk is it novel? Is this new? Is this something that we haven't seen before? In other words, the last paper I want to see is another scoring system for metastatic disease, or another short retrospective series of 20 years of allograft prosthetic composite reconstructions, because we've seen it all before and it doesn't mean anything. So the first question is it novel? The next question that we look at, is it interesting? Is it important? Is it something that is going to be useful in the world? And with regards to this paper, well, you know, for a consensus paper, it has put together a huge number of orthopedic oncology surgeons from around the world. In fact, I didn't know that there were that many. And they all turned up in Birmingham, which is quite a remarkable achievement, really. So Lee, well done for doing that. And well done for putting together a sort of pan-world committee. I mean, it's really quite an extraordinary thing to do. And I think this paper is important. It's a useful document for people to have in a subject about which there is often limited and very disparate evidence. So I think that the paper did meet the requirements for being novel, interesting, and important. The next question really is it scientifically sound? And this really, so I think I did speak to Faraz about this paper or about the meeting and said, my first comment was, I hate consensus papers. Well, I don't know if you have a view on that, Faraz. You're sort of hopefully nodding in the background. But I hate consensus papers because by and large, they're not scientifically sound. They're essentially a group of mates who usually meet in a cafe somewhere and come up with their view of the world. And I think that that is extremely dangerous for the orthopedic community. But I think to give Lee and the team credit here, they have done what they can to make this as scientifically robust as they can. But I think my general view of the consensus paper is that I think that they are something largely to be avoided. However, there are exceptions to every rule. The next point for anyone writing for the journal is it well written? In other words, if you start reading a paper, can you actually read it? Can you actually get a story out of it? And if you can't, it's a bit like bad handwriting. You're not going to get very far. So being well written is extremely important. The next part is, does the discussion actually discuss the relevant literature? Does it discuss other points of view? That's an extremely important part of producing a paper. And then, is the conclusion supported by the data? There's a huge number of papers that seem to be written where they make a conclusion, but that's got nothing to do with the data that's being presented. And then the final thing is, what is the message of the paper? What does it actually send out? If there's no message, it's very difficult to consider something for publication. What is it that the paper actually says? So I think this paper, I think what I felt that it achieved was it provided a document that was useful for a large number of surgeons that they could reference to. There was, in fact, a lot of literature that backed up a lot of those statements. And it also provided an opportunity for anyone wishing to research what really is a very wide-ranging subject, the whole of chondrosarcoma. So, I think that's my view about what we considered, why we considered it in view of this paper. Thank you.
Thanks a lot, Sam. Thanks for sharing that cheat sheet of how to get published in the BJJ, and hopefully we see a lot more acceptable publications both for Emma and for us in the future. So to conclude the discussion on this paper, Lee, can you just share with us what do you feel the impact of this paper is going to be? Is it actually going to change the way orthopedic surgeons practice? How does it help them? In brief.
Yeah, I think I agree with a lot of the points that Sam and Faris were talking about. I've published 280 odd papers where they're all scientific, and we've looked at it, but we did try to make it scientific as possible. So there's 200,000 word, 100-page document that goes with all the evidence, and that's free to download as well. So I think that for the reader and for the members of this audience, the question is to go and look at that question. They were supposed to just be day-to-day questions that we have every day, that I have, having done it for 20 years. So I hope it gives some framework for people to think about the problem more than give an answer. And a lot of the problems with consensus statements is there are lots of if, ands, buts and maybes. But really, it was a framework to think about a question and then to go and look up some evidence. And the trouble is with textbooks, they're often historical and they're often written by, a certain view, whereas having two different authors from different parts of the world or groups of authors come together to look at the same question, I think was also quite important, so that we got a world view on it. So I hope it's useful for people, but I don't want people to think that it is in any way sort of guidelines or that people have to adhere to those statements. It was really about what is the current concepts in chondrosarcoma around the world, and hopefully it will give a framework for people to think about it more carefully.
Oh, thanks, Lee. Thanks to all of you for actually giving us a bird's eye view of this paper and what it took to get it published and accepted. I'm going to move on further in publication and speak to Professor Faris Haddad. As the boss man of one of the journals with the highest impact factor in orthopedics, how do you see the challenges that are there in today's world, especially with artificial intelligence coming in, the pressure to, publish being there, and you having to sift the wheat from the chaff? And where do you see the world of publishing going, say, maybe 5 years from now, the challenges that will be there and how we navigate those? Faris, your views on that?
Hey, Jay, thank you. And it's great to be part of this discussion. I think I'll give you a brief editorial perspective. I just wanted to really echo what Sam had said in that before I speak about the generality of what we face, I think this is a really good topic to have profiled in this paper, in that it's a well-meaning, honest, well-intentioned attempt to help surgeons and patients. It's not the final word, but it actually does ask questions and answer some questions, and I think the community will find this useful. And that's not necessarily reflected in many other consensus meetings or consensus documents that we see. So it's a big kudos to Lee and the team for really having put this together. As the editor, I see the world maybe from a slightly different perspective. So maybe let's look more broadly and was what I think is going on, in case that helps you or helps the readers think about it. What we're seeing now in 2025 is interesting because we're seeing a massive volume of submissions, and there's varying quality. There has been a push that we've seen over the last decade or two that top 10% is really much better. Methodologically, there are good units producing really good work, but the tail is getting longer and longer, and there is a lot of poor quality research, and quite frankly, there's a great deal of research malpractice. So a lot of my job is screening out that problem at the front end. And just to give you as a perspective, if we say over 2,000 papers will come in every year, about a third of those will not even make it to the specialty editors like Sam, because I've seen a problem with them, or they're just not suitable for BJJ at the front end. That's in a paradigm where everyone thinks that everything they write should be published, and frankly put themselves under pressure and are under pressure for academic and other reasons to publish. So kind of managing that process is hard. And I feel, as you'll see, I feel that the reviewers and the review process are critical. So managing that burden on the reviewers and on the specialty editors for me is really important. So that's something that really challenges us to kind of keep the quality high and deliver to our readers, to your society, something that is credible and that is excellent and that will change their practice. Because there's a huge problem out there, and I kind of blame it on predatory journals, but actually it's beyond that, because the world out there holds a huge amount of information now that is not necessarily true. And there is a core of good quality literature that should guide thinking, guide debate, guide clinical practice. And open publishing should help people reach that. But in reality, what's happening now is everything gets either published somewhere or gets put on the internet somewhere and may be picked up by AI searches and so on, so that the average reader who's not distilling literature properly can get confused. So one of the key things in my world is how we teach people to differentiate what is credible research and what is junk science, because there isn't a big control out there other than starting to trust safeguards like the BJJ. You really don't know what is good and what is not good. You've got to stop and look at everything and look at it very critically. Lee's already alluded to this. In reality, we all understand and appreciate the evidence pyramid, but actually for every question, there is a level of evidence that we can reach. And that's a little bit of what I like about this work, is that they've looked at questions and found out the best they can do. Maybe in future we'll go a little bit higher, but in reality, the best we can do at any one point in time does not necessarily become a randomized trial. That's very, very difficult in many areas. So our role, I think, at the journal is to be a bit of a safeguard. It's to really give people something that is carefully screened, carefully vetted, extremely well written. This paper's been taken out of Lee's hands, out of his energy, his motivation, and the hard work he did. And frankly, it's been completely beaten up and rewritten in a format that is, we think, more appropriate and more easy for the readers. And so to that, we have to thank our reviewers. They do a tremendous amount of work to support us from that point of view. And then the primary editors beyond that, rewriting the papers. We also use technology to screen out plagiarism, to screen out all sorts of things that are unethical that we're trying to pull out. But that is really the key ingredient, is getting people to look at a piece of work and improve it so that what you end up with is something special. This is just a picture to share with you, a snapshot that Emma took of the editorial board. And I won't go through them one by one, but if you just look at the brains around that table, that is a phenomenal group of people to have focused on any individual paper. And you've witnessed it firsthand, AJ. It is fantastic what that sort of group can do, unless it's your paper being beaten up, of course. So what am I worried about in 2025? I think ethics are a real issue, and we've got to be really careful from that point of view. That's why increasingly we're insisting on study registration. You know, people should determine and transparently say what they're going to research before they do it, so that the answers are valid. If you're an editor, You worry about things like authorship, and sort of gift authorship should be on the way out, and conflicts of interest should be declared, because we're all conflicted. It's just a question of having that front and center so everybody sees it. We're increasingly aware of research fraud, of plagiarism, of dual submissions, dual publications. I dealt with an attempt at dual publication today. So those are all things we're getting really good at picking up now, because this is where the technology really helps us. And then probably the more ethereal but biggest challenge as an editor is quite how we disseminate this work. So I'm delighted. Thank you to Gautam. Thank you to you and the team at the Bombay Orthopaedic Society for allowing us to join you, because what we really want to do is for our work to reach everybody. And you're a big and important community, and we want to reach you. Yet on the other hand, there's a modern generation that doesn't really want to read papers. So having webinars, having podcasts, having infographics, having animations, anything that we can do to grab attention and reach those people, and maybe try and suck them in off an Instagram post, off a Twitter feed, off LinkedIn, just to come and have a look at the paper. That would be really key. Lee's written 100,000 pages of an appendix, and I'd love someone to download that and read it. But in reality, we're really just trying to get them on the edge with all those little dissemination tools to get there. I think I wouldn't be complete without my mentioning artificial intelligence. There are lots of positives and lots of negatives here. In reality, I think artificial intelligence will empower researchers to do good research, but it shouldn't be generating the research. It should be helping them plan studies, helping them collect data, helping them analyze data, but shouldn't be writing the papers, but it helps us in terms of cleaning up at the tail end. So I think AI is going to be a big thing, what we do. And then probably the last challenge, because you asked me to cover what gives me headaches, is that pressure, that sort of social political pressure to trump good science. And I think we will continue to resist that, because at the end of the day, what we want to do is publish the material that helps orthopedic surgeons and colleagues treat patients. We want to have patients front and center of what we do. So I think in orthopedics, we're in a great place. And we're very lucky at the BJJ to be at the heart of it, with the highest impact factor from the general well-known journals. So we want to continue on this journey. And if nothing else, what we want to help the Bombay Orthopaedic Society, your members, anybody who's listening, to discern the difference between good quality and poor quality work, so they can guide the practice and the care of their patients appropriately. So I hope that makes sense. I hope that helps you a little bit and gives some context to what happens in the background from the early days of Lee thinking of a study all the way through the work they did, what the reviewers have done, what Sam's done, and what finally comes out as a product that we hope your community will continue to read.
Thank you, Faris. That was very insightful and allowed a lot of people to get a peek of behind the scenes, the tremendous amount of work that goes behind actually publishing a paper. I mean, most authors, as you know, put in a lot of effort, but they don't see the equal or more amount of effort that goes on behind the scenes before it makes the final review. And so that was excellent. Thank you. Now,
we have got two questions. Sorry to interrupt.
No, go ahead. Sorry.
Yeah, there are two questions. One is for Faris. This question is from Dr. Basu from Calcutta. He's a spine surgeon. And he was asking about the problem that with artificial intelligence dominating research, and a lot of people and artificial intelligence is dependent, the results are dependent upon the data that it's fed upon. So how does one try to, as a reader or a researcher who looks up say, suppose we want to look up chondrosarcoma on the net, and we publish, and you get an artificial intelligence output there saying that this is the data on chondrosarcoma. How do we decide whether to believe that article or not to believe that article?
Yeah, so right now, ChatGPT is still busy hallucinating half the time. So I think that's why you have to go to Boom, and that's why you have to start to understand what you can trust and what you cannot trust. And although I think AI will make us stronger and better, right now, you mustn't just trust those digests that you get off Google or off all these little platforms that we all have access to. That's why the core orthopedic literature exists. Those are lay summaries, and they're often not as detailed or as useful as what you would get from the proper literature. So it's a great question. It's a real problem. And that's why you have to understand where the source of the really useful information is.
So a question for Dr. Jeys and Dr. Laitinen. Can you elucidate the role of radiotherapy in chondrosarcomas? We know that traditional radiotherapy didn't work for chondrosarcomas, but with the newer proton beam therapies, etc., is this going to be useful in the treatment of chondrosarcoma? The person who's asking is Dr. Garg from the All India Institute of Medical Sciences. He's a spine surgeon. And his question also extends to that if there is a chondrosarcoma of the spine, which has breached the walls and is entered into the spinal canal, often we are not able to get radical margins. So how do we go about post-operatively treating such a patient? Is there a role for any stereotactic radiotherapy, etc.?
Yeah, so obviously in the remit of this meeting, I'd recommend they went and looked at that question specifically because we looked at radiotherapy and there is some evidence, especially with proton beam therapy for skull-based chondrosarcoma and spinal chondrosarcoma and even positive margin resection after chondrosarcoma in high grades, that radiotherapy has a role. But I think the point that we answered in that question was that very specifically that chondrosarcoma remains a surgical disease. So we're trying to move away from the idea that these technologies will save us. They may have a role in helping us, but they don't necessarily have a role in primary treatment, though there are specific, very limited indications such as skull-based chondrosarcoma, high cervical chondrosarcoma, where there are some evidence that a radical radiotherapy has similar local control rates as surgery. But I think for a wider audience, it's important that the general consensus is that surgery remains the primary treatment and there is some limited roles.
Gautam, you're muted still. Any further questions?
No, that's all, Ajay. Thank you.
Okay, perfect. Then we'll move on to the next part of this webinar. And Emma, I'm going to ask you, I mean, Parikh did allude to that as well, but the journal has had to evolve over the years. And from becoming just a journal that published manuscripts, we have now moved beyond to try and educate and help young residents, consultants get their work published, be easier to search literature. So we'd just love to hear from you as to what the BJJ is doing on these fronts and what are the various tools that we have to help them.
Thanks, AJ, and thanks everyone for having me today. Yeah, so it's been really important for us to make sure that we are kind of evolving and pivoting to take the society forward and face the future. And it's like not working. And I just wanted to kind of quickly recap who we are. So obviously we publish the Bone and Joint Journal, and that is the most important thing that we do. But we are a truly independent publisher, which is something that's really rare these days. And we are really lucky because we are dedicated to orthopedics. We don't have to worry about other medical specialties. Whatever we do for you. The journal was launched in 1948, and I'm sure a lot of you on the webinar will remember the Journal of Bone and Joint Surgery British volume, our previous name, before we had our conscious uncoupling from the American volume. We are a registered UK charity, and our mission has always been and will always be to further education in orthopaedic surgery globally. And we publish across the breadth and depth of trauma and orthopaedics, as you well know. And we're really small. So there's 16 of us, and we do everything that we can in-house. And we have to put printing and typesetting outside of the building, but actually the slide Farith showed with the building is where we all are working for you. So these are our journals. We have 4 journals now, and 2 of them are open access, so they're free to read. I've put the QR codes on the slides, and I can share those with AJ afterwards if you want to visit them. I thoroughly recommend all of our content because it's all been peer reviewed and, as Farah said, is a beacon of quality. But we've also been busy, particularly since 2020. We have developed several digital products, the first of which was Ortho Media, which was born out of the COVID era, really. We recognised lots of conferences were being recorded, but that those recordings were being either lost or hosted by the associations in a very flat way in kind of sessions. So we've basically created a multimedia platform, and we're working with lots of conferences where we take their content, we are chunking it up into its individual talks, putting transcripts to those talks and hosting them on Ortho Media. The transcripts are really important in terms of being able to search and find what you're looking for. And I would say this is free to use. We've pivoted with Ortho Media slightly, so we're still doing lots of conference content, but we've also adding lots of surgical training videos. The platform is really powerful. You can create your own playlists. You are able to search via speaker, institution, conference. All of the speaker content gets an ORCID ID, so you can link that back to your own profile and gives you a full record of your contribution, because obviously these days your contributions are not just publications. And as I mentioned, the transcripts are really powerful. So we also have loads of exam prep videos on there, so I encourage you to use the site. It is free, and yeah, it's really powerful. Version 2 is coming soon, which will be even better. We also developed an orthopaedic search engine called Ortho Search. We recognised that there's so much content out there that often it's really difficult to necessarily find it, and also things like standards and guidelines and some of that grayer literature are really difficult to search. So we pulled it all into Ortho Search, and we created a taxonomy which we have applied to all of the content in there. So if you're looking for a place where you can find quality sources of content, Ortho Search is the place to go. Every result will be orthopedically relevant from the first page to the last page, which is not something you can necessarily say about tools like PubMed, where often you'll get so many results, it's impossible to filter them. We have customizable research alerts. So this allows you to create an alert that allows you to stay up to date across the breadth of the literature. Obviously, you can sign up to lots of different journal table of contents to get alerts when they publish new stuff. But this would collate research on a subject that you wanted to hear about, whether that was, I don't know, periprosthetic joint infection. It would then send you an email and let you know across the literature what's been published in that area. So a really useful tool. And you can create an alert, an account on there, and follow us on Twitter if you want to see the content that's being added regularly. Our latest tool is called Ortho Publish, and Ortho Publish is a tool we hope will help you find the right journal to publish your paper in, and also can assist you in formatting the paper for submission. So Journal Finder is a tool that will allow you to search the journals across orthopedics, and rather than having to go to lots of different websites and find the editorial board, you know, how the journal publishes, is it hybrid, is it open access, what is the fee, what's the impact factor, and having to go to lots and lots of different places, we've created a landing page for each journal so you can find all of those things at the click of a button. So we've tried to make it really easy for you to find the right place for you to publish your journal, your paper. So it looks a little bit like this. You get your search results. It's not just about bone and joint, it is across orthopedics. And you get a landing page for the journal with the external links on the side. So it should hopefully save you some time. This element of the tool is free to use, and hopefully it is of interest. The second part of the tool is the formatting tool, which does require payment to use, but we've kept the price really low. One of the key drivers for this development was the fact that we all know that lots of different journals have different instructions for authors, and they can be quite complicated to follow. And you spend hours formatting your manuscript. You submit it to a journal, only for that journal to reject it, and then you have to pick another journal to format it for, and spend another few hours getting it ready for the next journal. So we wondered what would happen if we created a tool that would allow you to format for the first journal in a shorter time, and also reformat at the click of a button. So this is where the clever stuff happens. You can choose a template for your chosen journal. We also have a universal template, which will help you get pretty far through most journal requirements. It will check things like spelling, structure of the document, whether the paper's been blinded, the reference format, whether all your references are cited, and whether they're all listed at the end. It will also check your figure quality. That's really quite whizzy, and will tell you if the figures meet the quality requirements of the journal you're submitting to. So this is just a screenshot from within inside the platform, just showing you how it looks and some of the errors. It is really powerful, and there's lots more templates coming soon. And the last thing I wanted to say before you get back to your orthopedics is we have a new product coming soon called BJJ Life. BJJ Life is a multiple choice question bank aimed at the FRCS Part 1, but actually fits most other single best answer requirements for training. So this will be hopefully live in July, and yeah, we're really excited about this, and this is our latest kind of project that we're working on. Thank you.
Thanks, Emma. That was nice getting to know as to the additional tools that we can use from a journal that most of us look at just reading manuscripts from. So thank you so much for that. Gautam, I'm not getting any questions in my chat box. So if there are any questions that you want to ask in this first half of the session.
I think these were the first. We didn't get any more questions than that, Ajay, regarding the academic talks. Regarding Emma's talk, I think we'll still wait for some questions. I'm sure that will interest a lot of people more. But I myself am amazed at the excellent availability of excellent tools by the BJJ. I was not aware of all these, and I certainly am going to be one of the first ones to start using it from tomorrow onwards.
Great to hear.
Yeah, and just to add to that, even we here in BOS have something called as an OrthoTV, where with something similar to what you do with Ortho Media, where the content of the conferences are uploaded for delegates who are not able to attend, and they can access that content later on. And even the current meeting that we are having, even though that will be on YouTube live, but then later on we can have that on Ortho TV. And I think we have Dr. Neeraj Bijlani and Dr. Ashok Sham who started that initiative around the same time, I think, in COVID. So that's very interesting how the two ideas are coming through.
Okay, great. So then, Gautam, we'll move on to the clinical part of the meeting. And
Yes.
thank you to everyone who took part on this. And actually, thanks to Gautam for giving us the latitude and the leeway to have this as part of the webinar, which was essentially supposed to focus just on clinical cases. So thanks, Gautam. I hope it was useful to all. So we'll now move on to the case presentations. And we've tried to keep these cases what I'd say relatively simple, because we understand that a large part of the audience is general orthopedic surgeons, not orthopedic oncology specialists like Lee and the others. And so we've not kept very complex cases. So we have Yogesh, who's going to be sharing his first case with us. Again, Gautam, I think you'll have to take the questions if something pops up, because unless it pops up on this chat box, I won't have access to it. Go ahead, Yogesh. You're muted currently.
All right, I hope the screen is visible. Are the slides visible?
Yes, sir.
Yes,
Yes,
yeah.
Okay, all right. Okay, so straight away we'll start with the first case. This is a 45 years old farmer who was having a complaint of pain in his right thigh over a 3 months duration. Later on went to have a fall while working in his farm and presented with this x-ray. I would like to have the inputs of the panel as to what they think this could be and their way of managing this particular fracture in the proximal femur. So request any one of the panelists to go ahead on the X-ray image. Maybe
Lee?
Yeah.
yeah.
Yeah, so there looks to be a permeative lytic lesion in the proximal femur,
Right.
which has caused a narrowing of the cortices. So it seems to be there seems to be some expansion happening within, but it is not well defined. There's a narrow zone of transition, as we like to call it, and that lesion is extending into the neck of the femur also, whereas the joint, the articular surface seems to be intact. So that seems to be the extent of the lesion on the AP and the lateral view.
Mhm.
And
There's no periosteal reaction that is obviously noted. There's no soft tissue, so seems to be something which is intraosseous, and we'll have to then obviously investigate further.
Yogesh, there's a fracture of the neck femur?
Yeah, that's right, sir.
Yeah,
That's
yeah.
one.
Yeah. Okay. So,
Okay, and if you see the lateral view, there probably is some subtle, lesion over there, which is probably which
Yeah.
looks, yeah, over there. Lee,
So,
you're
so
able to,
Dr. Lee has raised his hand. So I
yeah,
think
Yeah, I think for the general audience, it's important that you recognise that this is a worrying lesion. So there is some periosteal reaction there, and there's a cortical breach laterally and the fracture. So it's very easy to get taken just to look at the fracture and the big lytic lesion. But there appears to be a pre-existing lesion lower down, which looks less worrying. But then there's something that's happening up the top, which is more worrying. And so the periosteal reaction is away from the fracture site. And so I would be quite worried about this lesion. I'd be thinking about maybe a low grade or benign lesion that's become more aggressive in time. So I think for
right.
the general audience, the things that we're interested in is the age. 45, probably too young for a metastatic disease, might be, but that would be unusual. But also too young for a fractured neck of femur. So we know that the site is important, proximal femur. We know that the age is important, and then interpreting the X-ray. So we're not just looking at the X-ray, and also there's a 3-month history of pain there before. So there was obviously something that's been going on for a while before that fracture.
All right. So, Prateek, what's your preferred modality? The risk here is an intervention by an unsuspecting orthopedic colleague. All the points that
yes,
you
yes.
pointed out. Yeah.
So as Mr. Lee alluded to, it's very important to identify that this is not a normal fracture that happens post trauma or post osteoporosis. There is an underlying pathological process here which is happening, and a further imaging would help us to find out what that underlying pathological fracture process is. If this patient presents with this, we would obviously try to stabilize him, splint him, and then go on to plan our further investigations that we
So,
are
what would
doing.
you like to have? What would you like to do here?
So we would like to get a MRI done for this to know the exact nature of the lesion that is being there.
All right. So that's the MRI for you. Is Mishil around? Mishil, could you help us in understanding the MRI?
Yogesh, we had Sam and Minna also still
Oh yeah,
online.
great. Yeah. So Minna, I'll just
Yeah,
show other images also. You can ask me to stop wherever you want to sort of start describing.
yeah. You see what Lee already said, that it's worrying all the way distally, and then you see the extraosseous component, which immediately makes it higher grade, and we know that the proximal femur is the chondrosarcomas in proximal femur are malignant and are a little bit different, for example, from chondrosarcomas of the proximal humerus, so they tend to be more aggressive. So the MRI shows that we have tumors quite far away distally. So
Yeah.
and then the pathological fracture is actually might be even in two sides in the femoral neck, and then more in the proximal
Absolutely.
femur area.
So we have the fracture, we have the extraosseous soft tissue extension, all pointers towards an aggressive disease. So chondrosarcoma is what we were thinking about, and we all are thinking about as well. And we are worried about this long extent in the distal shaft of the femur as well, which was not very evident on the X-ray. Would you biopsy this, Sam?
Well, so we've got our local imaging done. We need to do some staging. So we need to do some staging of the chest. We need to we'd usually do a bone scan. We've got pictures that show the whole of the bone, including the joint above and the joint below.
Yeah.
So, so yes, I think that in this situation, we are concerned that this is a malignant bone tumor. We think that it is probably a malignant chondrosarcoma, and therefore we're going to do a biopsy.
Right. So interesting point. You said you would do a staging. Would you do a biopsy first or the staging first?
I think those things can run concurrently. You've got the primary imaging, but you put, in our country, we can't get everything done immediately. So we will request these things not sequentially, but all at the same time. So we will plan to do a biopsy as soon as we can, and we will put requests in for the appropriate imaging.
Okay, all right. So again, it'll biopsy.
And the other thing was that at this age, in what we usually see is, they can present with a primary somewhere with a metastatic here. Based on the X-ray, we could have thought that was one of the differentials. But once we have a look at the MRI, it is more obvious that there is something which is primarily happening here, and then it's better to get a biopsy done, and then go ahead with the staging.
All right.
The very important thing, of course, is not to go in and fix the fracture.
Yeah,
absolutely. Yeah. So that was the message that we wanted to give through this particular case. We did a biopsy, and the biopsy was reported as a grade 2 chondrosarcoma. And
so Yogesh, just to stress on what Sam said, I think what we need to insist is a pathological fracture is never an emergency.
Absolutely.
I mean, give some thoughts. And the general tendency for orthopedic surgeons, you see a fracture, bang a nail right to the front, or in this case, they talk of other things. We must insist that a pathological fracture is never an emergency, and it's well worth the time to give some thought and cross consults if required before you decide on a definitive plan. Yep.
Yeah. Right. So grade 2 chondrosarcoma, we did a staging in the form of a PET CT, which showed that this was the only lesion in the femur. There were no distant metastases. But the problem here now was the involvement of the entire bone almost. We can see the lesion extending lower down right up to the distal femur. So I'd like to know from the panel what would be their line of management. We have a neck femur fracture, we have an extraosseous disease in the upper third, middle third of the shaft femur, and we have a long lesion that goes down right into the distal femur. How do we approach this now? Obviously, it's not a chemo or a radiosensitive tumor. So, and he's got a fracture. What would you do next? Are you going to think about an salvage surgery, or are you thinking about an ablative surgery? He's a non-metastatic patient.
Sir, if I go back to the axial MRI cuts, I feel that the disease has become intra-articular. So you have disease in the joint with the fracture there. So my first thing is that my proximal femur will be an extra-articular resection, and knowing the length of the disease, I think I would go for a total femur replacement.
All right.
Because amputation, I think there is no contamination of the neurovascular structures as such, and that is why I would not contemplate an ablative surgery. But definitely, I will not be able to do an osteoarticular resection. I will have to do an extra-articular resection.
Yeah, but Mishil, wasn't there a paper from Tata Memorial Hospital which spoke about the intra-articular resections in proximal femur tumors, and they showed that there was no real difference in the local recurrence rates even after
No, 1 minute, Yogesh. Considering as the lead author, I'm going to clarify on that. those were patients that responded to chemotherapy. Those were for Ewing sarcomas and osteosarcomas. And then we could take a call, where we had the backup of radiotherapy, etc. I don't think in a chondrosarcoma that option does exist. So here I would agree with Mishil that this being a chondrosarcoma, I think we need to be safe because we don't have any adjuvant modalities to rely on. Lee's raised his hand.
Yeah.
No, again, just aware of the audience that we're speaking to as a general thing. I think this becomes a point where maybe for the very capable hip surgeon or trauma surgeon that that we shouldn't perhaps be dealing with this. They should probably come to a specialist tumor center because you can already hear the debate amongst the experts, which is what we found at Boom, about what we should do with it. So if these are people that have published a lot and seen a lot are still arguing or debating about nuances, then I think it's probably a sign that you shouldn't not be taking this on and taking a specialist opinion, because there is a debate about whether you can sacrifice the whole joint, whether you take the whole femur or whatever. But those are debates for specialist surgeons. But for a general audience, I think the first thing for me is I don't really want to touch this. This is
So Lee, what's your take on this? How would you treat this?
So there's a number of things which really worry me. It's a young patient with a very large tumor with an extraosseous mass that represents a very significant condition. So I wouldn't believe the biopsy is grade 2. I would be expecting this to be either differentiated or grade 3. I agree that it goes into the joint. And it's obviously arose in a pre-existing enchondroma. So for us, excuse me, we would do an extra-articular resection, and we would replace the whole area of the bone, which goes down just up to the above the joint. So we'd probably go for a total femoral replacement as well.
Okay, all right. Thank you very much. Thanks a lot. I think I'll stop here. We'll not have much of time for the other cases to be discussed. So over to you, Dr. Puri. I'll stop sharing.
All right. So you're not going to share with us what you did, or you're still waiting to do something?
No, yes, we did something. We did actually an intra-articular resection in this particular case with a total femur replacement. We had to take out the entire capsule, and we didn't see that there was any disease intra-articularly. We had to take it out. As the patient is following up for over 2 years now and currently remains disease-free.
All right. So anyway, you were lucky this time, but I think I would agree with what most of the people said, and we do an extra. Anyway, that's the beauty of orthopedic oncology. We have various opinions. So I think who's up next, Mishil?
Yeah, Ajay, when Mishil sets up his case, a quick question for the people as general orthopods. When you say total femur replacement, is it an allograft replacement or is it some kind of a prosthesis?
No, it's a prosthesis, because honestly, when the joint is involved, we've not had great success with osteoarticular allografts. And especially if you're going to replace the entire femur, it's going to be a metallic prosthesis. These have proven to be quite durable, and they've actually withstood the test of time. There are a number of publications. So it's a metallic prosthesis where we replace the proximal femur, we replace the distal femur, and we have coupling elements in the center so that the length of the femur can be accurately reconstructed.
And the survival rates of such prosthesis?
For such large disease, honestly, very often the prosthesis will outlive the patient, but the survival rates are not bad at all. And we'd have close to 55 to 60%, and maybe more 10-year survivals if the patient survives.
Thank you.
Yep.
So there's a question on the BOS channel by Dr. Neeraj Bijrani.
Okay.
So I'll just read it out. Which of the sarcomas of proximal femur has good prognosis and which has poor prognosis?
So that's a very general question. I mean, I don't think the proximal femur, if you look at it as a site per se, will have a different prognosis compared to anywhere else in the body. So an osteosarcoma, a Ewing sarcoma, and chondrosarcoma, these are the three main sarcomas that we see. Each of them would have their own survival, And there are a lot of other factors that depend on it. It's tumor volume, its response to chemotherapy, it's the margins, etc. So I don't think we can say which of these sarcomas would have a better prognosis. It's a very multifactorial answer.
Yeah.
Sorry, Neeraj, that's the best we can do. Yep. Mishil, go ahead.
Yes, sir. So now I have a 3-year-old boy who has complaints of pain in the left arm, which is radiating to the forearm. There is no history of injury and there is no history of fever. On coaxing the parents, there is a typical history that the pain is more at night and the boy wakes up in the middle of the night with pain. So this is what we got. We got X-rays of the bilateral humeri. And here you can see on the left side, I would ask one of the panelists to just describe this X-ray.
So you want to take a shot at it, Yogesh?
So, okay, so we have a 3-year-old boy, and on the X-ray on the left side, we can see that in the mid diaphysis of the humerus, there is a very well-defined lytic lesion. Most likely it's intraosseous, and I can see a small sclerotic focus or a calcific focus inside. And since you have just mentioned about the night pain, I would strongly suspect that this is probably an osteosteoma. I'd like to get a CT scan done to rule out or rather to confirm the diagnosis.
Would infection be a differential, Yogesh, considering it's a small child and, osteosteoma?
Exactly. Initially, there's, as Mishil mentioned, there was no history of fever. There is only night pain. There is no pain during the daytime. And on the X-ray, we can see that, it's a pretty well-defined lesion. For an infection, I would have, expected more of an lytic shadow over there, maybe a bit of a periosteal reaction. And yes, my further radiological investigations like an CT and MRI would also help me in differentiating.
But sir, the lateral view, the one in the bottom right,
yeah,
where you can see some solid, I think, periosteal reaction in the middle.
Yep.
I think it's just a cortical thickening as a response to the primary lesion. I wouldn't put it as a periosteal reaction per se, as a classic periosteal reaction in infection or a malignant neoplasm.
So like you said, sir, we went ahead with further investigations, and unlike the general orthopedic surgeons, the first extra investigation we do is an MRI and not a CT. So in this case, the blood tests and an MRI was advised. The CRP was high, which was 8. Rest everything was within normal limits. And this is what we have, from the MRI. And these are the axial cuts.
Lot of edema. Okay.
Sam Lee, any ideas on this?
So again, I think for the general audience, when we're trying to interpret X-rays and MRI scans, the important thing is to look at how the bone is reacting to the lesion and what the lesion's doing to the bone. So we've got a smooth cortical thickening without any significant peri-reaction. We've got a lot of perilesional edema, but all inside the bone with a focal area of non-enhancing lesion. On the X-ray, again, X-ray is always really useful if you go back to the X-ray. On the AP X-ray, you could see a very small cortical little erosion on the AP, and your focus is taken to the central lesion. So I would be suspecting that whenever tumor and infection come out of your mouth at the same time, that there always remains in the differential diagnosis. So my working diagnosis would be probably as a osteomyelitis, given the age, but the location's a little bit unusual. But I'd certainly want to exclude anything more sinister in there. But you've got a smooth periosteal reaction. So I would probably go for a biopsy, but I would be hoping that this is some kind of low-grade infection given the low CRP.
So Lee, that's an interesting point. Sorry, that's an interesting point that you raised, that even for an expert like you, it's challenging to differentiate infection and a tumor. And for a general orthopedic surgeon, I mean, they would see infection, I think, 15, 20 times more common compared to a tumor. And the inclination would be to rush in, sort of do a curettage, lay it open, and try and decompress the entire thing. Unfortunately, if it turns out to be a sarcoma, then you have sort of crossed certain bridges and boundaries that can have a very poor prognosis. So I'd just like some tips from you for a general orthopedic surgeon that if you suspect infection, do you go in immediately, or would it still make sense always to do a biopsy or doing something?
In my lectures, I often show one picture of a Ewing's and one picture of an infection, both in the same bone, and I can't tell which is the difference, having done it for 20 years. So I don't expect a general person to do it. You can have low CRPs with infection, and you can have high CRPs and ESRs with Ewing. So the blood parameters don't often help us. So I think the important thing is if we're suspecting something, that we confirm our diagnosis before we go ahead and do it. So for us, even infection, even CRMO, which is something we see in the UK more than acute osteomyelitis, we'll always have a biopsy, even if it's radiologically typical.
Thank you. Yes.
Oh, Mishil, do we, in cases like this, we will typically ask for a CT scan along with the MRI. Do you have a CT cut as well?
Yes, sir.
Sorry,
So from there,
Yogesh, just to clarify,
Yeah.
I mean, maybe we are sort of judging because we know the final diagnosis, but why would you ask for a CT scan in addition for every case to an MRI?
No, not in every case. Where I feel that the CT scan is going to add up to an information for, in this particular case, when I see a sort of a sclerotic or a calcific lesion within that particular lytic area in the mid diaphysis, that's where I would also like to get at least a sort of a screening CT done to find out what exactly is happening.
Okay.
Even though infection would be one of my differentials, but since he specifically mentioned about the night pain, I'm just interested in knowing what's happening.
So I am presuming that you are thinking of an osteoid when you want a CT scan.
Yes,
So
yes.
anything particular that you would specify to the radiologist if you're looking at a CT scan?
Yeah. Yes. So I would ask for a CT scan with a 1 millimeter cut specifically in the mid diaphysis of the humerus, and that's what I would write on my requisition.
Because classically, if they do a conventional CT scan at 5 millimeters, they could
Yes.
possibly miss a nidus if it's there.
Yeah, that's right.
Mishil, go ahead.
yes, sir. So then the MRI was reported as an infective or an inflammatory lesion. For me, the differentials were infection, LCH, and osteoma.
Yeah.
And what we did was, this is a question to the orthopedic surgeon. What would be your options with this information in hand? Would you start IV antibiotics considering it's an infection or just an inflammation? Would you go in, do a surgery, do a curettage, a graft or whatever, just keep it open? Or would you do a biopsy, which we have already discussed? And the answer is that we should do a biopsy. And as a rule that we preach everybody, that you culture what you biopsy and you biopsy what you culture. So when you do a biopsy, the tissue is sent for histopathology as well as for culture sensitivity. Now, this was what was reported on the biopsy. A CT-guided biopsy was performed, and the result was that the above might represent an inflammatory process, and clinical correlation is advised. And you can see the last line, the culture sensitivity had no growth. So now here, the orthopedic surgeon thought that, okay, if it was an osteoma, it would have come in the biopsy. Now that they're saying it's inflammatory, it could be a transient process, and let's wait and watch and maybe treat this patient conservatively. So now this is what was done. Treated as an inflammation for 3 months with ibuprofen. There was no relief, and that is when the patient came for a second opinion. And this is when, like Dr. Panchwagh said, that in certain situations, in certain cases, when your differentials have certain diagnoses, you would want a limited CT, a thin slice limited CT of that area. And this is what we got.
Sam, your thoughts on that?
Well, again, it doesn't tell you the answer, does it, AJ?
Yeah.
It doesn't tell you what it is. I think I'd like to be able to run through that because I want to see where the biopsy has been, and you'll be able to see a biopsy tract of when the biopsy was done, and then you'll also see whether there is a lesion and whether you've got lesional tissue or whether you've missed it.
Mishil, you have more slices or?
So I have only these two slices, but sir, like sir rightly mentioned that if you see the axial view, the biopsy tract is not visible. I mean, I don't see any breach in the bone through which, you could have gone into the lesion and taken out some representative tissue. So what I feel is maybe the needle was not in the lesion and whatever tissue they got was just the muscle or the cortex, and that is not reported correctly. But based on this,
yeah, Gautam has a question.
Sorry, Mishil, I have a question.
yes,
What
sir.
sort of a biopsy would you prefer in these bony lesions? Would it be a CT? Most of the CT scan people, they use a very thin needle. And for these kind of a bony lesion, is that adequate to get the CT guided biopsy? In the spine, where I do spine surgery, the yield of CT guided biopsies has been very poor, and we generally prefer to do a core biopsy using a Jamshidi needle.
So again, sir, it is the surgeon's bias, and I also feel the same that a Jamshedi needle core biopsy gives us more yield, and these are lesions that we can target nicely even on a C-arm if at all we need some image guidance, and we do not need a radiologist for this. But it again depends on where the patient is, what facilities he is able to get, and most of the times we see patients with CT or USG guided biopsies.
So I think, Mishil, what we need to stress is that actually we need to, maybe interact with the radiology colleagues a little better. Because if you see the multi-axial Cook's needle, you do get them in larger diameters. I mean, not as large as the larger Jamshidi, but adequate enough to get adequate tissue. So if we interact with our radiology colleagues, because just like orthopedic surgeons, we don't see too many tumors compared to the rest of routine orthopedics. Radiologists too are constrained by the same. Very few of them would be really experts in sort of musculoskeletal oncology. So we need to interact with them. And Gautam's point is well taken that, you get a Jamshedi needle, but the problem with the Jamshedi needle is it's not multi-axial. And under the CT scan, if you want more than one core, then that can become a challenge. So using a good large Cook's coaxial needle will help.
Mishil, would you get a bone scan done here? I would probably think of getting one done just to see if we have that classical double density sign or not. Since we are still thinking whether this would be infection. And,
so, because unfortunately I don't have enough cuts, but this CT scan on the films and with the report was classically reported as a typical osteoid osteoma.
Okay.
And now my options are that what do I do to this? Do we go for a surgical excision? Do we do the CT guided drilling? Or do we go for RFA?
Oh, so Mishil, you were able to see the nidus on that cut which you showed us?
Really? Sir, unfortunately not on this cut, not very clear.
But you did see one?
Yes, sir. So you can see sir, that there is a lighting lesion with a sclerotic rim.
Right?
But
that's what I feel.
Sorry?
The entire central intramedullary lesion appears to be a big nidus.
Yes, this one.
Yeah.
So isn't that unusual for us to have an intramedullary osteoid osteoma? If you look at osteoid osteomas, they're generally thought to be cortical lesions. So just for the interest for the routine orthopedic oncologists, this is actually basically an outlier for an osteoid osteoma. You do see intramedullary osteoid osteomas, but they're relatively uncommon. So this can be challenging to diagnose for those who don't deal with tumors regularly.
Yeah, but this is too well defined for it to be something like a sequestrum. Though it's a little big in size for a nidus, that history and this kind of a CT scan presentation, I would probably have added a bone scan as one of the investigative modalities.
Yeah, but again, a bone scan, Yogesh, is very general. It will tell you activity. I mean, even in an osteomyelitis, it will be hot.
Yeah.
It's not really going to help us, but I mean, a thin slice CT, and if Mishil has seen the cuts, I guess, and diagnostic of osteoid osteoma, then we need to see how to address that.
Yeah, Lee has raised his hand.
Yeah, Just before I have to go, but again, just for the general audience, I think the importance of this case is that if something doesn't smell right, then don't always just go by the biopsy. So the first thing is always use a level of clinical suspicion, and that's why we work in multidisciplinary teams, radiology, pathology, and surgery. And the second thing is that close observation, maybe 3 months if we're worried about it, a small Ewing's is a little bit too long. But again, do no harm in the first case. And if we've got a reassuring biopsy, but make sure that we follow that up with a serial imaging just to make sure that it's not progressing. And now we're much happier that this is not a primary bone tumor, not a Ewing's or anything like that, because it hasn't grown in that time. And then you can debate as much as you like about how you treat it. All right, I'm going to have to go. Take care.
Bye. Thanks a lot, Lee. Pleasure having you with us.
Thank you.
All right, so that's what Mishil did. Perfect.
Thank you.
Sam, would you have done something different compared radiofrequency ablation, CT-guided drilling, open surgery?
I think I'm just slightly worried about it. I'm just slightly concerned that that's not, we've not nailed the diagnosis. I think, my preference would be there. I probably, if I'd failed on the biopsy and it was clear that the biopsy had not gone into the nidus, then I would have gone back and done another biopsy. I think if I've just biopsied the area and I've still not got an answer, then I think a period of observation is probably not a bad idea. But then if I'm going to go and do something, I think really it would be helpful to try and get some more tissue. And it could be, you see, it's possible it could be a Brodie's abscess or some sort of infection that's just been decompressed when we've done the RFA. That's a possibility. So unless we've got actual histological sort of confirmation of it, then I'm not sure that we've really quite got it. Because there are some things about that are a bit atypical in my book, really, for it just to be a simple osteoid osteoma.
Good. I think we agree with that. And it basically, again, highlights the challenges that you face when you deal with these unusual lesions. Thanks, Mishil, for sharing that rather difficult case. Prateek, time for your case now.
Yeah, is my screen visible?
Yep, it is.
Yeah. So what we had, first of all, good evening to all, and thank you to BOS for this.
I think it's not on screen sharing mode. We are still seeing everything on your screen. So maybe you could just show it to people. On slideshow.
Yeah,
you could put it on slideshow and then we could just see your...
Is it now seen?
No.
Yep, it's seen. But all right, go ahead. Anyway, yeah.
Okay. Yeah. So it's a 14-year-old boy who had presented to us with a pain over the knee since a few months. He was doing his activities of daily living, but then he realized that the swelling is progressively increasing along with the pain. When he presented on examination, that there was a spherical swelling near the knee joint, and there was a slight rise of local temperature. The swelling was cystic to feel, and it was tender. And by the time he presented to us, his knee range of movement had reduced to only between 70 to 90 degrees. And this was the X-ray that was taken. So yeah,
the X-ray is not seen, Prateek. We are still on the first slide.
It's moving here. Wait.
We are seeing only the history slide. Maybe you could select the X-ray slide on your screen.
Yeah, on the left side you can select that.
Is it seen now?
No. I can see them on the left in your slides list.
Yeah.
Now,
okay. Is this better?
Yeah. Can you move to slideshow, Prateek, down there where your arrow is?
So I did that, but
okay, but never mind. Then I think you'll have to move on the left. You'll have to scroll down.
Okay, but is the X-ray visible now?
Yes, now it is.
Okay, so I'll just zoom that up, and I'll
Yep.
Like this. Yeah. Okay, so that's the X-ray that we had.
Mishil, your thoughts on that?
So I feel it's a lytic lesion with a soft tissue component on the medial condyle of the femur.
Yeah.
And on both AP and lateral view, I don't see any other pathological fracture as such. Neither is it very permeative.
And I can't see a periosteal reaction as well, at least on this.
Yes.
Yeah.
Can't see it, sir. Yes.
So there's a big soft tissue mass, lytic lesion involving the meta-epiphysis of the distal femur.
Yep.
And as sir mentioned, there's no periosteal reaction here, but it is just seems. So is it something which is arising from the bone, or is it a soft tissue mass eroding into the bone? Like
I think
what-
it's arising from the bone. I
Yeah.
mean, had this patient been 5 or 7 years older, my first diagnosis would be in a giant cell tumor. Because he's still skeletally immature, though it's seen in younger patients, I would still have giant cell tumor as one of my differential diagnoses. But I think an aneurysmal bone cyst would be another differential. These would be my the benign differentials would be top of the list compared to a more malignant tumor, because I'm not seeing any osteoid, I'm not seeing any periosteal reaction. Yogesh,
But-
Sam, your thoughts on that?
So there's a pretty big soft tissue mass and an aggressively growing lesion. Though the intramedullary part appears to be very well, there seems to be an intermediate zone of transition. I would say there is a little bit of a subtle, sort of I don't know whether there are pony spicules over there.
Yeah.
But I would be a little worried about a more aggressive lesion, like maybe a telangiectatic one.
Okay.
Telangiectatic Chondrosarcoma.
Okay.
But yes, there could be it could be an aggressive GCT or an aggressive aneurysmal bone cyst as well.
Let's have international opinions, Sam. Diagnosis.
Well, I think what the international diagnosis is, it needs further investigation, doesn't it, AJ? It looks aggressive, and
Correct.
you know, with these things we can look at patterns and everything else,
Perfect.
but we're getting some feeling of patterns here, but it's aggressive. We need to find out. That's
So,
really what we
Prateek,
need.
I presume you got
Yes,
additional investigation
Yes,
before.
we have. But before that, I
Imaging.
just wanted to ask, sir, you mentioned aneurysmal bone cyst as one of the differentials.
Yes.
How common is it to have a soft tissue mass along with it? Like usually we would think it's located
Yeah.
within
So-
the bone cystic.
So it's basically it expands the bone, but
Yeah.
sometimes, and that also is a selection bias, because we see the larger aneurysmal bone cysts that maybe a routine orthopedic surgeon doesn't see. We
Yeah.
do see them where they have actually broken through the cortex and there is a soft tissue component, but that is an exception.
Yeah.
But I wasn't really very, very convinced that this could be a malignant lesion. Not that I'm going to go and do something without further investigation. But as I said, I was thinking more of a benign pathology, a giant cell tumor, but this being a young patient, that's not what I thought of. Or
Yeah.
terrific.
So this is what we were thinking about when we are looking at a lytic lesion in a differential in a child. So for the ones which are non-aggressive looking, and if it's less than 10 years, we are looking at something called as Langerhans cell histiocytosis. But if it is slightly more than 10 years, then we have got fibrous dysplasia, fibrous cortical defect, simple bone cysts, aneurysmal bone cysts, and enchondroma. Now, out of all these, aneurysmal bone cyst seems to be the one which is more likely to fit. But as Dr. Yogesh mentioned, that it doesn't look entirely benign. It seems to be a bit aggressive. So then in that case, what are our differentials for aggressive in above 5 years? Then it is obviously the sarcomas come into the picture. Osteomyelitis is also there, which we discussed in the previous cases also as one of the differentials. So then, as our international colleague asked for, that is the further investigation that was done in MRI, and that is showing the coronal T1 and the axial T2 scans. Are we any wiser?
Not really.
Yeah. So, I mean, honestly, my diagnosis seems to go out of the window, because classically in an aneurysmal bone cyst, you do see fluid levels,
Yeah.
which we can't see on this.
Yeah.
So,
Do we have a T2 weighted image?
Sorry, Yogesh?
Sorry?
Yeah, do we have a T2 weighted image? The axial.
So this was the one that we had in those series that was there.
No, we must have had. You must have had. It's not put up on the slide.
Yeah.
Yeah. So I would still
Could this
on
be
this,
still an sorry? Please go
I
ahead,
would
sir.
still say giant cell tumor, skeletally immature, very unusual, but it doesn't with the soft tissue component there and that sclerotic rim that I can see on the condyle. I'm still in favor of benign, though I could be wrong.
I think you're probably right. I agree, AJ. I think it probably is that, but you know, it's got a very concerning look about it, hasn't it? All quite aggressive.
So as sir mentioned, there seems to be a sclerotic border on the inner side here, and where it seems to be restricted. But this is all a solid component, and there is no fluid which is seen, which is classically seen. But does that rule out telangiectatic OGS, or is that still in the picture?
We would still keep that in the picture. I mean, obviously, it's going to be a biopsy, and then we're going to decide. So no one's going to rule out an aggressive malignant tumor in this at all.
Yeah. So now the twist was that when he presented to us and we investigated, his hemoglobin had come down to 4, and there was some deranged coagulation profile. His CRP was 22.5, and the other parameters that were checked, the serum ferritin and the haptoglobin, were also very high. Now does the panelist want to chip in as to what was
So, Yogesh,
going
my
on?
question to you is, I presume all these investigations were done only because the HB was 4. That wouldn't be a routine sort of profile when for any malignant tumor, right?
Exactly.
Okay. Yeah. So just for clarifying, this is not what we would routinely do for every tumor.
Yeah.
It's just because the hemoglobin was 4. Yeah.
Mostly alkaline phosphate is normal.
Yes, the alkaline phosphatase were normal.
All right.
The vitamin D was normal. The calcium was slightly low, just below the lower end of the range, but phosphorus was also normal.
Okay.
And so just for the audience, why what was the thinking behind that question, sir? Like,
No, it's a very, I mean, except for the age, I would have loved to rule out a metabolic disorder, but the age wouldn't fit into something which would be something like a metabolic
Yes,
disorder.
but
In this
Yogesh, a
particular case.
metabolic disorder is not going to give a hemoglobin of 4.
No.
So this is something
no,
for our...
unrelated to this,
Yeah, so
not
I
in
think
relation with the low hemoglobin.
this is now becoming more and more multidisciplinary. I think this is where our hematology colleagues need to be brought into the picture to try and
so we
help
were a
us.
bit worried with this picture, so we got an hematology opinion where they because we are worried, are we missing some hemoglobinopathies which is presenting in an unusual way, or is there some factor deficiencies where, is it like a pseudo tumor where we are missing, where it is bleeding into the tumor? So after their opinion, actually, and
So
that was...
Yogesh, sorry, Prateek, can we go back to that slide? Your
Yes.
previous one. Now, just for the general audience, a coagulation profile is something we do before every biopsy, because you really don't want to do a biopsy and have to stick your finger into it because it's bleeding endlessly. So the answer here would have been, we wouldn't have biopsied this with a deranged coagulation profile at all till we got a hematology consult and sorted out that issue, because that would be more of a problem if we did stick a needle or someone unfortunately did an open biopsy as well. Yeah, sorry, go ahead.
Yeah, so that was the clinical picture, just to add up to the entire scenario that is going on.
Wow, had you shown me that, I wouldn't have ever diagnosed an aneurysmal bone cyst or a giant cell tumor at that time. I would have gone with Yogesh's diagnosis. Anyway, yeah.
So once we got the hematologist opinion, who said that there is no hemoglobinopathies going on, there's no deranged bleeding happening elsewhere. So then we went ahead and did the biopsy. And in the biopsy, the differential diagnosis that they gave was between aneurysmal bone cyst and giant cell tumor of bone, with diagnosis of aneurysmal bone cyst being favored.
So my question to the panelists again is, can a pathologist mistake a telangiectatic osteosarcoma for an aneurysmal bone cyst?
Yes.
extremely unlikely, especially in an institute like TMH.
No,
That's
All right.
This shows the importance, doesn't it,
Yeah.
of working in a multidisciplinary team and being able to put together the radiology, the clinical picture, and the pathology together. And sometimes things just don't fit. And then you have to go back to the pathologist and say, this, we're not happy that that fits the picture that we're seeing.
And
Yeah.
that's one of the reasons we're actually, at a small amount of cases, maybe even sometimes think of doing a second biopsy, because if the jigsaw, all the pieces of the jigsaw puzzle don't fit and fall into place, it may be worthwhile taking either a second opinion. As Yogesh said at TMH, that option really we don't explore because we believe we would have the best people to base their diagnosis on, but we would occasionally do a second biopsy to reconfirm that we are not missing an area that is actually giving us the correct diagnosis. Yeah, go ahead, Prateek.
Yeah, so during all this workup, when we were trying to make sure that we are not missing out on something, there were a couple of weeks that had passed on. So we got a fresh radiograph done, and this is the fresh one. And again, something similar to what he presented with, and again, no aggressive features seen like a periosteal reaction or no further erosion of bone seen, except probably the soft tissue mass has increased. So then what next then? Now that you have a pathological diagnosis of supposedly it being a aneurysmal bone cyst, so then would you go ahead with sclerotherapy or would you go ahead operate?
Let's ask Mishil, Sam, and Yogesh what they would do.
Yeah.
Surgery, curettage, and reconstruction.
Sam?
Are we sure we've got the diagnosis? That's my question. Are we sure we've got the right diagnosis? Because I'm still not sure, so I'm going to go for a further biopsy first.
All right.
I'm just not happy that we've got a child with a hemoglobin of 4, deranged coagulation, and we're going to call it an aneurysmal bone cyst. I'm just not happy about that.
So
I'm going for a further biopsy.
All right. So biopsy comes out the same.
So,
okay.
Prateek, do we have a USB 6 done on this?
No, not yet. Not on this, because that USB 6 is not available. Histones were done, which turned out to be negative.
Negative. Okay.
Yeah.
Okay. And still it says benign. I mean,
yes, it says benign. That was the main key takeaway from that they didn't find any malignant features. And the point of doing that repeat X-ray was also that to see if there are some malignant features which make themselves obvious in that interim period.
Gentlemen, what does histone signify? I suspect GCT.
Correct.
And what is USB 6 signify?
Prateek.
Yeah, so histone is one specific marker that we have now available for giant cell tumors of the bone. So for these specific cases where we have this discussion, whereas it is ABC, GCT, or telangiectatic OGS, we run this additional markers. And if histone is positive, then it is more or less confirms that it is giant cell tumor of bone. So a similar marker we have got for aneurysmal bone cyst, which is USP 6. And the clinical significance is that because very often clinically and radiologically, you can have a ABC presenting or a telangiectatic OGS presenting very similar to what an ABC does. So if we have the specific marker which tells us that it is positive, then we are sure that it is not a telangiectatic OGS, because many of times the MRI findings of telangiectatic OGS and ABC, the fluid levels, the destruction that is seen is very similar, and it becomes very difficult to differentiate just on main hematoxylin or eosin staining. So that is why they've got these specific markers these days.
Thanks, Gautam, for bringing us back on track. I think we were veering to be a little more oncology specific. Yeah. But there are special markers, as Prateek said. We don't use it in all cases, but in difficult diagnosis, they can be used. So, Prateek, I think in the
Yes.
interest of time, we need to step out. What did
Yes.
you do?
So then we, as I mentioned in this slide, we went ahead because after discussion in a multidisciplinary meet, it was decided that consider all things considered, there it looks benign, but has to be addressed. Sclerotherapy would not have addressed that extraosseous mass. So we went ahead and did a curettage where the extraosseous mass was taken out en masse and the part eroding into the bone was curated. Now, the interesting part is that this is crossing the epiphysis and metaphysis. So, in a 14-year-old boy, we had to make sure that we are anyways destroying it. So, we just curated that part. The one near the articular surface, we have put in a piece of bone, a femoral head, which has been shaped in the condyle. And then rest of the cavity is filled up with cement. So, something that we call as a sandwich reconstruct, and that whole thing was then stabilized with a plating. And then we have the final histopath, where again they didn't find any malignant features. In fact, what they saw was a cystic lesion, locally active with focal areas reminiscent of a tenosynovial giant cell tumor.
So terrific. So finally, a benign tumor, whether we disagree with this final diagnosis or no, is a matter for speculation. But in this particular case, fortunately, no harm done. Thanks a lot, Prateek.
Yeah.
Can I ask, Ajay, was this entire thing removed completely? Were you able to manage a complete resection of this tumor? Because what is the chance of recurrence of this
No.
tumor?
So, Gautam, for a benign lesion, we try and balance the morbidity of our sort of treatment as against the functional outcomes. So here is what we do is what is called an excision curettage. The extraosseous component is completely excised, but this being a young child, rather than excise the bony part, which would have then forced us to put in a megaprosthesis, we do a curettage over there. We take care during curettage. We use burring, etc. The role of using additional adjuvants like phenol, etc., is still debatable. At TMH, we don't do that. We rely on just doing burring. And I would say in giant cell tumor, which is the largest portion of aggressive bone tumors that we would see, our rate of recurrence would be about between 15 and 20%. So I would still say 8 or 9 out of 10 patients would get away without a recurrence. In this particular case, that's a call we would take. The way we decide is that after a curettage, do we have enough bone left for skeletal and structural stability? If the answer is yes, then we would still choose the less morbid option of a curettage rather than doing a resection and reconstruction.
Thank you. That's great. Is there any role for post-operative radiotherapy?
In giant cell tumor?
Yeah.
Absolutely not. I mean, for this audience, absolutely not. The only place for post-operative radiotherapy in our setup would be a Ewing sarcoma or a metastatic disease.
And after such a tumor, would you follow it up with denosumab?
Again, the role of denosumab post-treatment, almost no role. I mean, there will be people who will debate it, but denosumab, if anything, is given as either a neoadjuvant or when you are not planning surgery, when you using it as a definitive modality. The role of denosumab post-operative, post-surgical excision, I mean, I'll be quite clear, no role for this audience.
In fact, there's a very nice paper written by someone called A.J. Puri that was published in the Bone and Joint Journal on the use of denosumab in giant cell tumor. It's an excellent paper.
Any other questions, Gautam, from the audience?
No, Ajay, I think this is about it. But you'll be happy to know that there are about 100 viewers still on the platform having a look.
I think that's a credit to our panelists. And I'd just like to take this opportunity on behalf of BOS to thank all of you for joining us, being here throughout. And Gautam, you as a representative of BOS, thank you for giving us the opportunity to share our experiences and be part of this webinar.
Thank you, Ajay. I think it was a fantastic webinar. And after the early part of the webinar where we learned about chondrosarcoma and the current management of this very difficult lesion, and then learning about all the activities of the British Bone and Joint Journal was very enlightening. I think the cases were superb. They highlighted to us the need. And as Sam kept on continuously saying that he was not happy in most cases because he wanted a very good diagnosis before jumping in to do to manage the case. And I think that is very vital for most of the audience who's here today, that you need to establish your diagnosis before you start handling the tumor in such circumstances, because you may make situation much worse if you've not established a diagnosis. Thank you very much, Sam, for staying here throughout the seminar with us and sharing
Thank
your
you for having
incredible
me.
experience. Ajay, thank you very much. This was a superbly convened program. And I would like to thank all the three young oncosurgeons, Prateek, Mishil, and Yogesh is no longer young. He's my
Yeah,
age.
exactly. Thank you for calling me young.
So
Yogesh is
thank you
still the
very much.
fittest of the no, Yogesh is still the fittest of the lot. So he
Fittest. Yeah. And thanks to the entire Ortho TV team for taking us through this webinar. Thank you, Jeys, for being here to help us coordinate that. Good night, and I hope to see all of you for our webinar next month. Good night.
bye. Thanks everyone. Bye bye.
Bye.
Bye bye.